Hello, this is Matt Link, President NuVasive. In our COVID-19 Q&A discussions, we spent considerable time focusing on the learnings from COVID-19, how the virus has impacted our global healthcare system, and how this impacts the spine and orthopedic markets. Given recent guidance and recommendations from the White House, CMS, and joint statements on recovery from various societies, including the American Hospital Association, we'd like to shift our focus on the road to recovery. How do we meaningfully move forward and provide care to those in need? In a new three-part series, we will focus on critical success factors for reopening and providing care, important considerations to our protocols, patient selection and sentiment, and other important operational measures, and anticipated changes coming out of the pandemic, including ASCs and telemedicine. Taking part in our series is an esteemed panel. Dr. Hanjo Kim, orthopedic surgeon and director of the Spine Fellowship at the Hospital for Special Surgery in New York City. Dr. David Okonkwo, neurosurgeon and director of the Scoliosis and Spinal Deformity Program at UPMC in Pittsburgh, Pennsylvania. Dr. Nitin Khanna, orthopedic surgeon at the Orthopedic Institute of Northwest Indiana, based in Chicago, Illinois. And Dr. Bobby Kalantar, orthopedic surgeon and chief of the Division of Spine Surgery in the Department of Orthopedics at MedStar Georgetown University Hospital in Washington, D.C. Each of them have a unique practice demographic and professional experience. Before we get started, we'd like you to learn about their professional experience, their institution, spine practice, as well as context of their current COVID-19 environment. Dr. Kim, let's start with you.
Thanks, Matt. So my name is Hanjo Kim. I am attending spine surgeon at the Hospital for Special Surgery in New York and the Spine Fellowship Director. And the current situation as far as my practice, as you know, in New York, we have stopped doing all elective cases. And my practice normally, however, is comprised of about 50% spinal deformity surgery and about 50% cervical spine surgery. And right now it's about 0% of either one, maybe more towards cervical, because the hospital has allowed some sort of what we call essential surgeries to happen, but the volume of the spine service is basically 5% of what it has been during this crisis. The hospital has converted over to a COVID positive hospital, and HSS normally does not have a tremendous amount of ICU beds. I think we have about 5 ICU beds, but during this surge, converted to 25 hospital beds, so about a 600% increase, and started taking on COVID patients, mostly because of our partner across the street at New York Hospital Cornell. So that's sort of our current situation.
Let's go to Dr. David Okonkwo next.
I'm David Okonkwo, a neurosurgeon at the University of Pittsburgh. I've been in practice for 14 years. I run our neurotrauma service at our level 1 trauma center, and then I have a large elective spine practice with a heavy focus on deformity. I trained back at UVA with additional deformity training with Chris Shaffrey when he was at UVA. And for us in Pittsburgh, we were ready for a surge that didn't happen. Our cross-state colleagues in Philadelphia have suffered a substantially higher burden of COVID-19 cases than we have in Pittsburgh. And my entire practice is in our quaternary referral center, level 1 trauma center, which was expected to be ground zero of Pittsburgh for a coronavirus surge. That surge just hasn't happened in Pittsburgh, and I think there's a lot of reasons for that, not the least of which are some of the same things that Nitin and others have pointed out, which is that a very aggressive attempt and effort was instilled to change patterns in an effort to, and that's patterns on personal levels and professional levels, in order to limit the risk of a surge. So we're in an interesting position in Pittsburgh because we were prepared both from a hospital perspective, but also a PPE perspective for a substantial surge that didn't happen, we are well equipped to then pivot our discussion now as an institution to returning our attention to patients with real problems who have been waiting on the sidelines appropriately, but are now also appropriate for re-engagement and a discussion of how to get back to business and turn the lights back on for patients with urgent and ongoing significant problems.
Dr. Khanna?
So this is Nitin Khanna. I've been in private practice. I have a clinical appointment at the Indiana University School of Medicine where I teach medical students. I'm 18 years out from my ortho training at WashU and my fellowship at Rush. I have a heavy emphasis on minimally invasive spine surgery and outpatient surgery. And in our area, the COVID environment was significant. I think our governors did a really good job in terms of Pritzker and Holcomb looking at what happened in New York to put the shelter-in-place orders in pretty quickly and aggressively, and I think that's probably helped decrease what the ultimate numbers would have been had they not placed those orders. Overall, I think that we had a very quick shutdown, and so I had 11 cases scheduled probably within a span of 5 days that all had to be canceled while I waited for these things to sort of sort themselves out. So since the shelter-in-place order was put down, I've actually only done one surgery and on an outpatient basis, and I've been holding off on bringing the other patients back, which I've now, as of yesterday, started to add back onto the schedule.
And finally, Dr. Kalantar.
Yeah, I'm Bobby Kalantar, an orthopedic spine surgeon at MedStar Georgetown Hospital. Been there for 10 years now, and primarily a degenerative practice, 50% cervical, 50% lumbar. And, spine is a pretty high volume specialty at Georgetown between the orthopedic department and the neurosurgical department. And we have been shut down since March 19th, really following what was happening up in New York and the concern that with the proximity and the density of the population in DC, it was a quick reaction to basically shut everything down, and we have stayed that way. We're in an interesting environment in DC because we kind of bleed into Maryland, Virginia, and DC proper, which have had different reactions and different timelines from a government leadership standpoint to what to do with the crisis. And we have had to balance all of those reactions in, I think, making some of the decisions from an administration standpoint in the system, which I think is also going to reflect on when we decide to start opening up. It's not a simple one-to-one with one government. They're essentially running on different timelines, and that's part of the issues that have to get worked out here going forward.
Thank you, Bobby. On today's webinar, we'll focus our discussion on the critical success factors to determine whether or not we're prepared to open up access to a broader range of elective and scheduled procedures, and specifically to provide a wider range of care for patients. We'd love to hear specific considerations you and your health system are thinking about. We know we won't be doing this in an environment where COVID-19 has gone away. We'll be doing this in an environment where COVID-19 is flattening, or better yet, where deaths, hospitalizations, and cases are continually decreasing, showing improvements in public health. Let's start with Dr. Okonkwo. What are you considering as you open up broader access to care in your institution?
At the macro level, we can look at coronavirus as three eras. And the first era was the shutdown era. The second era will be, and is as we are now entering, the testing era. And the third era will be the vaccine era. And the word unprecedented is used probably too often in politics in this millennium, but I think historic is a more appropriate word to use because we have had a precedent for this. Our country had to face this in 1918. We had to face something on a smaller scale with polio circa 1950. And now here we are in 2020 with coronavirus. There was the shutdown era, which made sense. It was uncertainty. There was a lack of clarity about how large a case volume was going to occur and over what time. And so our country appropriately instituted a shutdown policy really from coast to coast. Now we're moving into what really should be viewed as the testing era, which is we are getting back to business, but we are getting back to business under the circumstances where we can expect COVID-19 to continue to have sporadic cases and the occasional outbreak of cases in a particular community or communities. And the safest way to reignite our economy and the safest way to return to business in the hospital beyond just being closed for business in preparation for COVID-19 cases is widespread testing. It's why it's built into the White House's gating criteria to move into phase 1 of opening up America again. And testing is really going to be the foundation of turning the lights back on as a prelude to the third era, which will be the vaccine era. It is unclear how long it will take for a vaccine to emerge for COVID-19, and when a vaccine does in fact come onto the market and it is a clinically validated vaccine, of course, the circumstances will change considerably. But between now and then, this will be rooted in widespread testing. So that's really been the focus of our institution's pivot, is to recognize the low incidence of coronavirus in our community, the very, very low census of coronavirus in our hospitals, the even smaller census of ICU patients who are COVID-19 positive, and certainly as a percentage of available beds and available ICU beds, it's extremely low. In fact, 2% of our ICU beds are currently occupied by COVID-19 cases in our mothership hospital of Presbyterian Hospital. Once we can ramp up the testing, and there are a lot of testing options that are out there, but once we ramp up the testing, we will be able to have a similar ramp up of scheduled surgery in collaboration with the processes that are rolling out the widespread testing. So that's really how we're viewing things here. We've taken into consideration the guidelines that have been put out by the White House, by CMS. We've taken into consideration the roadmap outlined by the American College of Surgeons and the American Hospital Association in conjunction with the American Society of Anesthesiology. We have vetted those gating criteria about the burden of COVID in our community and the burden of COVID in our hospitals, and then balance that against our capacity to do large-scale testing. And so we put a roadmap in front of us for how quickly we will ramp up and return and get close to that 100% or perhaps even a surge of 120% capacity for scheduled surgery.
Thanks, David. Nitin, how about you?
So I thought David's points were excellent and very well thought out. And clearly he's been having a lot of meetings with senior admin on everything, probably up in including a state level discussions to make sure they do this thoughtfully and cautiously. First and foremost, in my mind, is the safety of the staff and the patients. And that's really where I start my decision making. Our hospitals have a much higher COVID burden. And so the questions that abound with me are focused on, well, if there's this many COVID patients in the hospital, how can we wall off an OR? If a patient has to go to a floor and there's nurses, communicating back and forth and staff communicating back and forth, how do you ensure it's a safe environment for that patient? I think in a market like ours, the ASC really provides a excellent opportunity to move those straightforward cases, still deliver the care, but be able to build a very safe pathway. So in terms of doing that, I reached out to a lot of my colleagues from around the US and even internationally from various specialties to get their take and get a feel for what they were seeing in the ICU, And then I went to start building a full safe pathway for the ASC. So that would involve when a patient comes to the ASC, their family members aren't allowed in. They drop the patient off. They wait in the car. We call them after the procedure. Everybody in the ASC is wearing a mask the entire time. Only one surgeon is allowed to operate at a time within our ASC. And so even though they could utilize 2 rooms, we have to keep the room closed between cases to allow the air to recirculate. I think in an ASC setting, it's a lot easier to create a safe environment for, again, staff and patients than it is in a major hospital system, because I just think it's harder to control all the other variables in a major hospital system. I think David's in a unique situation where he has a major hospital center and a major quaternary referral center, yet they have a low COVID burden.
Thank you, Nitin. Hanjo, can you share the factors you and your colleagues are considering to open up access, given the situation you're facing at HSS being in New York City?
Yeah, so I think, the thing about HSS is that we are, like I mentioned before, we only do orthopedic surgery at the hospital. So to take on sort of a general hospital role was sort of a very big transition for us, and a deployment that we never thought would happen, but we definitely wanted to help our neighbors at New York Hospital Cornell and do the socially responsible thing, and try to help in the current crisis. So that being said, New York Hospital and Cornell and HSS, we have a great relationship, and they appreciate the surge that we have performed. I think if I look at the surge numbers, we are functioning at 500 to 600% above capacity for these COVID patients in the ICU beds, while New York Hospital, they are functioning at about 200 to 300%. So they definitely appreciate the efforts that we've made. And because of that, they've also stated that their goal, once their ICU beds free up, is to take back the COVID patients in our ICU currently, which are located in the ambulatory surgery centers upstairs on the 9th ambulatory surgical floor, which is the 9th floor of our hospital. So that transition has already started. And like I said, I was covering the ICU the last few weeks, and my most recent shift, the census has already dropped about 50%. I recently checked in with the team this morning, and it looks like it's getting even lower. So once that starts to free up, the plan for HSS is to do a terminal cleaning of those operating rooms so that they could go back to doing the ambulatory surgery cases up there. And that is going to be in a phased format. And the hospital has dedicated 2 floors now to not only intubated COVID patients, which is the ICU, but also COVID positive patients that are just being monitored and that are not utilizing ventilators. And as far as going back to doing elective cases, I think the hospital's approach is going to be, number one, to ensure that we're doing the socially responsible thing. The last thing we want to do is try to open up our doors and say, hey, we're going to do elective cases no matter what. We're going to start now. I think we're taking an approach that's cautious and definitely very, very deliberate. Governor Cuomo mentioned that he's going to extend the shelter-in-place order in New York until May 15th. So initially, when the hospital was thinking that it was April 29th before Cuomo changed this, we were thinking that we would go back to some sort of functioning as far as elective cases are concerned around May 4th, that particular week in May. But because of this now being extended to May 15th in the state, we probably will not start a significant number of cases until mid to late May. And I think we're just keeping a pulse on everything that's going on in our neighboring institutions as well. Like I said, we're trying to do a very socially responsible graduated return. And when we do return, it's not going to be 100%, bam, back to normal. It's probably going to be a phased response, starting out with patients who are somewhat of a more urgent case, and those patients who have comorbidities, which put them at very, very low risk for having mortality related to COVID infections.
Bobby, with that in mind from Hanjo, I'd love to hear your perspective on what you're considering, not just for your facility, but across your health system, given your health system stretches from DC up into Baltimore and throughout Maryland.
Yeah, sure. We, I think, reacted fairly quickly, like I said earlier, seeing what was happening in New York, where the epicenter was happening, and putting in the stay-at-home orders and shutting everything down. And we haven't really seen the surge numbers to a level that has overrun the hospital. We do have at Georgetown about 100 patients admitted with it, but that includes patients just being hospitalized. The ICUs are not overrun as of now. We have a COVID ER and a non-COVID ER, and we have all sort of signed up for shifts to manage the non-COVID ER unless physicians start to get infected and have to be pulled from the workforce. So we have a good plan in place, and I think because of all of the governmental precautions that have been put in place, we have not seen that surge. Maryland had took the brunt of it, primarily in Baltimore, a little bit more, and so they were getting close to capacity, but that has seemed to level off as well. Some of the smaller MedStar hospitals, like Southern Maryland, for example, they met their ICU capacity very early in early April and began transferring intubated patients to Washington Hospital Center and to Georgetown to help manage the overflow there. They seem to be leveling off as well. The plan as it is now is looking at the middle of May for some kind of return to business. And I echo what Hanjo said, is that it's going to be in a phased way in which we address the backlog of patients that we have that need surgery more urgently, the myelopathy patients, and those kinds of patients, and then more of an ambulatory outpatient procedures that won't stress the inpatient system in volume. The MedStar is trying to decide and determine if this is something they can do system-wide or if they can just do very regionally, such as in DC, and then move into Maryland. And some of that will depend on the government, local governments and regional governments in Maryland and DC. Currently, the DC mayor has put out some modeling that states that we may hit our surge in June, which is a little bit different from what we have been functioning at based on some of the more national modeling systems. So I think part of that level of discussion is going to have to be between our leadership and even our local government, because that can be very conflicting information to a patient. If the local government is keeping shelter-in-place rules and stating that a surge will be on its way, and we are at the same time trying to open, I think that creates a very scary environment for a patient to determine if they want to even be operated on. And I think that's something that's probably going to play out in many different regions in the country, trying to help a patient understand, is this the right time to move forward with an operation or not?
Thank you all. I appreciate your insights and comments on how we approach recovery from this pandemic. In our next episode, we'll continue the discussion of recovery and focus important considerations as it relates to patient demographics and selection, OR protocols, and other specific operational changes. Thank you for joining us.